Super. Thank you to all of our speakers. That was really fantastic. While we have people come to the mic, maybe if you all could just start off. You've all chosen some metrics. We saw Nick's red and green. There's obviously a list of metrics that he picked. What do you think are these are in our practice or my experience, what have been the things that make the most difference? If you were going to follow 3 or answer Ron Klein's question, what do you think are the top metrics?
That's a good question. I think that there's some overall outcomes metrics that we're studying in terms of utilization. We're trying to find something that is a little bit more timely than 5-year survival, which we've studied up to this point. But utilization metrics are helpful. Those still, there's a delay on when we receive that information. Data from CMS comes a little bit later than what we'd like. We understand there's a lot of information to parse. So right now we're limited to process measures. Did we complete a distress screening at every visit? Did we complete a pain assessment at every visit? If either of those found something, or if the depression screening found something, did we adequately and appropriately move that patient along to the next point in the care continuum to resolve that? Those are the things that we're looking at now. It's timely feedback, and I think it's able to help us reinforce on a daily or weekly basis, are we making a difference, and are we acting appropriately, and are the people that need help actually getting it?
So I could list about 20 process indicators, but I don't think that's what you're going for. If you're looking for,
wonder if you said it was 100 pages of metrics. I thought, how do you boil
yeah,
it down?
A1N has 100 pages of metrics. Our reporting tool, the GWPN bot, patient barriers and outcomes tool, has about 80 pre-generated reports, but within those, I would say the top 3, one thing that hasn't been really highlighted today, and I'm not sure if it will be tomorrow, the University of Alabama did an amazing study that showed reductions in hospital, unplanned hospital admissions, reduction in ER visits, savings of around $760 per patient with a comprehensive navigation process that included high-risk patients, geriatric patients, included advanced directive counseling. So I think they deserve a really big kudos, and I think that they, in terms of the cost piece, if that study hasn't done it, I don't know what will. But in terms of looking at things that we could capture in common, time points I think are still really important. Are we getting people to care at, within reasonable periods of time, and is that the same across sociodemographics? I would say adherence, so are patients able to adhere to treatment, either whether that's appointments or whether that's oral therapies or what have you, and patient-reported outcomes. I mean, if I had to choose 3, I think those are what I would choose if we assume cost is kind of already demonstrated.
Super. Question?
Thanks. I'm not sure this is on. Yeah, that was a really terrific session. My question is for Mandy. You gave us a lot of structure, a lot of metrics, a lot to think about. One of the early comments I think you made, if I got this right, was to use the right tool for the job, something like that talked about customization. So I was wondering, were you talking about different sets of navigators with different skill sets? Can you explain what you meant? Were you talking about different domains of what people need?
Yeah, absolutely. So I think I mentioned early the domains in common for competencies, but I think what you're asking is, later in the presentation I said hire the navigator for the right job. So, if you're a hospital located in Chelsea versus a hospital located in Boston versus one in DC, who is your patient? I tried to get to this with some of the implementation questions. I'm sorry, I always have too many words. My daughter gets that from me. I'm like, oh my God, too many words. But what is the major problem you're trying to solve? Our healthcare system is like entering a foreign country. If you don't speak English as a first language, if you are not literate, if you don't know how to use health information, if you're gay or trans, if you're an immigrant, there's a million ways where that's exacerbated. So what is the primary issue or issues that we're trying to solve within that system? And then what is the skill set you need to get there? So if most of your patients aren't adhering to therapies because they're dealing with so much social stress that they're depressed, you should probably be hiring social workers, right? If you don't have good symptom management, then you really should start with nurses. If most of your issues are logistical and have to do with getting to appointments and having someone assess the social support structure and how people are going to get into care, then you should be matching your navigator skills with the need in the system. So I hope that that answers your question.
Thank you.
Over here.
Türkan Gardiner from Pragmatica again. Everybody needs to be congratulated for making available to us the resources and online facilities that are available. My question is for Mandy. When you showed us all the online courses and certificates that people could get, have you thought of making available CME or continuing medical education credits for relicensing of physicians?
Sure. So we have a number of online trainings at GW ranging from, well, our new team training, which will be really focused on cultural sensitivity. That does come with CME. Our cancer survivorship trainings come with CME and CNE. Our navigator training only gives CHEST credit right now, but we try to balance. We provide continuing education credits for free for all of our trainings, but we try to balance who we actually think are going to take the training. And I think there's only been a handful of physicians that have taken our navigation training, but there's lots of physicians that have taken other more clinically focused trainings. So we try to customize. Thank you.
Thank you.
I wonder if maybe Nina wants to comment. In our organization call, I think you said something to the effect that the COC was actually ripe for revision, and that the beginning conversation of what might go into that revision is starting now. And so I don't know if you have any thoughts based on what's been discussed already, or if anyone else does on that kind of direction and comments there.
Yeah, thank you. I think in saying that, I think we feel like we set the stage for programs to start thinking about patient navigation and the value of looking at that concept. And by sort of setting that stage with, first of all, a community needs assessment, I think that that's, in some instances, kind of a given at this point. And so if you've looked at your data and you've looked at your situation and you've done some focus groups perhaps, or you're doing a patient satisfaction survey, or you're doing some of that kind of thing to collect the right information from the right source to inform your navigation process, that becomes sort of operational. And so I feel like we're ripe to sort of move to the next phase, and that's really looking at, I think, the cost-benefit information, the staffing structure information, the competencies that need to be employed to move the marble with patient outcomes and that kind of thing. So I think that perhaps down the line in a few years we can strengthen our standard language in some of those ways.
So Nick, not to put you on the spot, but I'm going to anyway. So we heard a lot of presentations today about different programs and the struggles the programs had in trying to figure out how to fund navigators. They were funding them out of grants or philanthropy. The grants went away, trying to beg, borrow, and steal a few dollars to support their programs. And that's clearly one of the themes. It's obviously variable across the programs, but I would say that it's a national problem. You talked about some of the financial benefits that you've seen in your program. I think one of the challenges is that you have lots of stuff going on. You know, navigation is not the only variable.
Right. Confounding factors for sure.
Pardon me?
There's confounding factors for sure.
Right, and so it's not the only variable, but clearly financially, you showed us one example, but I know you have other examples of financial benefit as you've gotten into the OCM model. You know, as an administrator, how do you sort of gauge that to figure out, you know, how to rationalize hiring navigators? How many do you hire? You know, what's the point where you're really having both clinical and financial benefit and sustainability?
That's a good question, and there's an easy and direct answer that some people have started to look at, and then there's the more difficult answer that I touched on briefly. And just to recap, the difficult answer is getting the clinical team that's going to be benefiting from and working with the navigator to articulate what are some of the clinical outcomes that we expect to be somewhat directly associated with the work this navigator's doing. And there are some of those that are now being monetized, and it's easy to go from preventing readmissions or reducing no-shows and convert that into a dollar figure. There's plenty of ACO contracts that are paying for getting people into screening, and those are things that we can easily plug navigators into. Something that's a little bit more direct, and I hope it isn't too unsavory, is there's work that can be done out of the hospital's budgeting system to kind of do a randomized control study or retrospective, I should say, in your own budget system to compare the rates of service utilization for navigated patients versus non-navigated patients. And I think that there's definitely a couple of systems that have been able to demonstrate that having navigators inside of your system is a good way to, if not save dollars by preventing costly care, it could be a good way to generate money. And just as we use that to figure out, is it a good idea to hire a physician or not, you could certainly do that with navigators. I've seen institutions that have been able to show that navigators help make the healthcare system a little bit more sticky. The patient is less likely to leave for a second or third opinion if there's a navigator. At the University of Minnesota, we studied the number of patients that came back after a second or third opinion and cited the navigator as the number one reason for them coming back. If you're competing with a number of different institutions and you've got private practice physicians on staff that prefer those other institutions, sometimes the navigator can be an effective way to keep the patient inside of the system and keep that information inside of the system. That's not necessarily a clinical answer, but it is a quick and dirty way to demonstrate a dollar figure back to hospital administration.
So I don't know if you're going to be here tomorrow, Nick, but you're a progressive administrator at a very progressive program. Should be congratulated for what you've done, but maybe at the end of tomorrow as we wrap up and we think about what we can do to move navigation forward at the national level, you can help us to understand how we could convince other hospital administrators to think the way Nick does.
Sure. Thanks, Nick. Thanks to the whole panel. Nick, you have the biggest heart of any MBA I've ever seen. I know that's a low bar, but I wanted to give you that compliment here. I sort of wanted to address the elephant in the room, which is that in the current payment system, the quote unquote the money you save by preventing a readmission or preventing an ED visit is actually revenue you take from your hospital. So congratulations to Carolinas Medical Center, congratulations to Lancaster for having the foresight to say that even though we're losing money in the short term by not putting patients back in the hospital, sending patients to ED, we're preparing for a future world where that's going to be important. So and obviously in an ACO environment, a bundled payment environment, all the things you guys are doing have financial payoffs, and I think the hard sell here is in a fee-for-service world. That's a harder sell. So I think that's going to be one of the issues as you address it. I think the other point, and it sort of addresses the same issue before, is I think some of the questions were raised before is how do we get someone to pay for the services we're providing for navigation. So in a bundled payment world, in an ACO world, you don't need to be paid for that service because the money you save the system comes back to you as revenue. So it's sort of, I guess, sort of just opening up perhaps for tomorrow. I think the conversation is going to be a lot of what you do depends on how you get paid and how you're incentivized. And OCM does provide $160 per member per month or per beneficiary per month to help fund those enhanced services, and hopefully those enhanced services. Certainly the information you showed in terms of your costs decreasing. Again, in an ACO bundled payment world, those are fantastic. And I hope they're as meaningful in a fee-for-service world. And I have concerns that until we get to a bundled payment world, they may not be.
So I think the question is, how do you transition from fee-for-service to bundled payments? And that's been described administrator to administrator in our secret meetings. Like moving from one canoe to another while you're in the middle of the lake. And there's an uncomfortable point in time where you've got a foot in each canoe, and you don't want it to slip out from underneath you. And I think that there's something that you need to do, or there's something that you can do immediately, but there's also something that you need to do when you recognize that change occurring. The thing that you can do when you do have a foot in both canoes is that there are some fee-for-service services that don't make any money. And if you have a choice of where to prioritize reductions in utilization or changes in how you practice, that's a good thing to focus on. For some hospitals, it's inpatient care. For other hospitals and practices, it might be infusion therapy if you're not a 340B institution. For others, it might be emergency department visits. And so those are ways for it to be a win-win-win. If it's an emergency department visit, the patient's not experiencing that kind of problem, the health system isn't losing money on that visit, and the payers aren't paying for it. Eventually, though, we need to start focusing on things that are going to start to hurt. And because it's going to take a long time to change clinical practice and culture to begin working on some of those difficult things, you do have to have the foresight and the support of the health system executive team to begin making some of those changes in advance, because it's going to take, in some cases, probably years to change the system to a different type of behaving and using care. And that needs to start even before we're completely capitated or bundled. And that will be difficult. To make that a little bit easier, I think you need to have an eye on when that's going to happen and start engaging some of your commercial payers to make a switch in a fairly rapid point in time. Once you are starting to get to the point that you recognize that you're about ready to manage care and take on risk, you need to have some of your payers teed up to begin converting all of the contracts that you have towards that model. We've begun having conversations with two of our top Blue Cross payers who are very interested in doing that. And for us, that'll be the point at which it just makes sense to begin moving everybody to that end. We're a little bit worried about that because we don't quite have all of the data and results that we'd like to demonstrate that this is going to be low risk. But I think OCM is a safe place for us to begin experimenting with bundled payments, and we view that as being part of the future anyway, with where some of the commercial payers are beginning to focus.
Go ahead.
Hi, good afternoon. This is Ephraim Flores from Mass General. Thank you for the sessions, and all the panelists have been fantastic today. I think that throughout the day we can see that the mounting evidence if very positive towards how effective navigation is. If this was like a chemotherapy, it would be fast forward into production, into clinical trial, into clinical practice. So eventually, and in the near future, they will be moving forward with changing policy, and they will be covered by private and public payers. But what I was thinking of, when you get coverage and advanced policy, then there are increasing regulations, and some of these programs are creative to be molded to fit the needs of a population that suffer from different socioeconomic factors, and is a population that is always evolving and not stagnant. The issues that affect them are like housing instability or losing a job, transportation, are things that, even immigration status, are things that are always evolving, but also inspire creative solutions, such as, for example, that photo when you show the hydration, how we can benefit. You know, you did a simple solution, and just to see that. And my worry with increasing, or how do, my question to the panel, instead of the worry, like the question would be, how do you envision maintaining that creativity to fit the needs of the population that you serve, while hitting the metrics to, hopefully getting paid and covered?
So I'll take that first, but these guys might have a more applied answer. You're hitting the nail right on the head in terms of, for, probably 4 or 5 years, I've been saying I don't want reimbursement for navigation in terms of our fee-for-service environment, right? We need to be moving toward this value-based purchasing environment, because if we try to reimburse for navigation services as a service, what's going to happen is that those with better insurance products are going to get the services, and those who need navigation the most are not going to get it. So, how do we compare apples to apples and make sure that we're taking care of the people that we need to take care of the most? As Ron was talking in my implementation science head, I was thinking, oh, this would be a really cool observational study if you looked at all of your OCMs and looked at kind of what are the, and maybe you're doing this in your evaluation, but what was the tumor type and what were the sociodemographics, and how much time did the navigator need to spend based on those different variables? And there's this really cool thing that is called qualitative comparative analysis that no one's using, but people will use. It's going to be the cool thing in the future, that allows you to look at variables like multiple variables in cases in that's a really powerful tool for observation-based studies. So I think, doing some kind of look at, and again, Tracy's study, the implementation factors, and what does it take to get a patient with a particular profile through care to good outcomes, and how do we stratify that? Because we don't know, maybe 160 is great for some patients, and maybe it's completely inadequate for others, and an overpayment for others, right? And what's the average? And that's what I've been puzzled about for 5 years. Like, what is the algorithm? How do we create that algorithm so that payers aren't overpaying, but institutions can take the risk of hiring an adequate number of navigators to navigate the appropriate caseload for the appropriate acuity? So, not a great answer, but I appreciate the question.
I really like that question, and it's interesting to me because the top thing that we were worrying about over the last couple of years is burnout and compassion fatigue. And as more and more requirements are put in place, and as reimbursement falls, and there's a lot of pressure to think about headcount, I think you ask a good question, because how do you keep the team engaged, and how do you bring everybody to a higher level of performance, but do it in a way that's energizing and not punitive, where you're trying to make things better and not simply keep your job. And I think that's an important question to ask. Our number one thing that staff bring up that they worry about is compassion fatigue, and how do you rebound from an unexpected or a disappointing loss, or the fact that it's hard to refill your cup at the end of the day. And I think that the oncology care model for us, one of the surprising things is that it's been helpful with that. It helps to recalibrate everybody towards shared goals. Good for the patient, good for you, good for the company. And it really challenges people to focus on solutions that are actually going to work. It's no longer, is this a good idea? But we need to really do some research and figure out, have we identified the correct cause, and have we identified an effective solution? And we'll try it, and if it doesn't work out, let's try something new, but we're not going to lose sight of the goal on what are we trying to accomplish, and how can we prove that it works? And I think that's kind of fun. But the more important thing is that the implementation team for this project, it's not me. I'm probably the least important person. I'm like the foreign minister that'll come and explain to you, here's what we did. And it's also not the medical directors. It's really the staff, the nurses, the schedulers, the secretaries, and the medical assistants and the social workers and navigators that are seeing the patients day in and day out. That's the implementation team. And if we're not talking to them, then every project that's been like that in the past really hasn't done anything. It's been a boardroom consensus conversation. We've agreed to do something and we publish minutes, but nothing happens. And this has been the first project where, because we have the people that are caring for the patients, we see things decided in the boardroom that move to the exam room within 24 to 48 hours. And that's been rewarding to see happen, because we can respond to those issues at the daily huddle. Hey, is this working? What do we need to try tomorrow to fix that? And so we're trying to make that creativity happen every day.
So for anybody who tweets, I think everyone should tweet what he just said and give him a big kudos. How do we fix systems instead of just trying to keep our jobs? So if there's a tagline for this meeting, I think that should be it.
Super. And we have a couple minutes left, and I don't know if the team maybe wants to comment on one last topic that we talked a little bit about in our call, which is all of you really highlighted how important it is not to keep reinventing the wheel and to share these resources, and have very thoughtfully put out all of the materials, which I think is fantastic. Do you see a future for a centralized national patient navigation resource where instead of having your collection of 10 websites where all of these different things live now, that Nick could say, here's the EHR Epic version we made, and someone else can say, this is what we've modified from Cerner, and someone else could say, here's our approach to it, so that you have a one-stop shop where somebody who's just starting doesn't need to start where Chris was 5 years ago and be like, let me learn all these things and create these tools, and could maybe get a jump start on it.
So we tried to create that with limited uptake. It was called the Generation and Translation of Evidence, or the GATE. You can see it at cancergate.org. But it was supposed to help facilitate communication across clinicians, researchers, and patients. But I think that clinicians and navigators tend to underestimate what they can contribute and are so stretched for time. It's hard to, draft and submit something. So there's an infrastructure for that, at least an online infrastructure, not a lot of staffing behind it. I think with any innovation, there's always going to be multiple sources of information, but where we can help disseminate what we know is going on to each other, I don't know, that's maybe the best we can do, but.
And it's interesting because we have a cancer forum at the Commission on Cancer where we ask all of our 1,500 accredited programs to submit, resources and best practices and ideas, and we have very little uptake to that as well. I think that that's a challenge. Through the Comprehensive Cancer Control National Partnership, we've got some sort of nationally based coalition, if you will, that tries to gather resources around certain topics, and I think that we've had some sort of success in that model, but it's a good thing to think about. And I'm not sure what the solution is, but it's a good thing.
It might depend on demand. I'm a basic scientist, not a navigator, and what happens is if enough people ask me for my cell line, I give it to a repository because I'm tired of being asked for it. So the demand makes it push that stuff forward, so might work the same way.
I would say I think it's interesting that you haven't had that much uptake, because typically whenever I either go out to a site or, they're constantly wanting all of that information. Will you share your job description? Will you share your policies? But people want it, but they don't think they have it to offer. So people don't realize that they have valuable information that other people could benefit from. Oh, it's the people who are posting it that you're having problems with. Oh, gotcha.
Super. Well, I want to give just another warm round of applause to this panel and the whole day.